Here we will be dealing with twin pregnancy in short. As you can see, the definition is written when multiple fetus develop in the uterus. It is known as multiple pregnancy. If it is the number is 2, then it is called a twin pregnancy. Now, the types here we have dizygotic versus monodizygotic. In dizygotic, basically there are two ovas that come and then are fertilized by two different sperms. As a result, we have two non-identical twins. But in monozygotic twins, basically the one sperm fertilizes one ova, and then after the formation the zygote divides, and hence both the twins are identical. Now, regarding the ratio of how much identical it will be, you can see here it's 1:80 for triplet squared, and for quadruplets it's cubed. Next, choriocity and amniocity. Chorion, we have to remember, is the outer layer and amnion is the inner layer. The amnion develops later on the 10th day, and the chorion develops earlier on the 8th day. Depending upon that, we can classify the chorionicity and the amnionicity. Here you can see, since the chorion is the outer membrane, the amnion is the inner membrane, and the outer membrane divides first. So three classifications is what's important. If the embryo divides within, say, 3 days or 72 hours as per the book, or here we can see as 4 days, we can clearly see that the zygote is formed, but chorion and amnion are formed differently for both of the fetuses, since both of the membranes are formed 8th day onwards, and after the division of the zygote has already taken place here. But if it happens within 4th to the 8th day, the outer membrane, that is the chorion, it's already developed, but the amnion develops on the 10th day. So it will have a common chorion but a different amnion for the both fetuses. So we have monochorionic and diamnionic. And similarly, if it develops in 8 to 12 days, then it might share a common chorion and a common amnion, that is MCMA. DCDA is mostly seen in case of dizygotic twins, and Siamese twins develop if it's more than 12 days. Regarding this table, you can see pause it and see it in details for your own reference only. But the thing of importance here is basically, if you see, if I hold it like this, you can see that in dichorionicity, the number of layers is 4. So 2:2, 2:2, 4. And in monochorionic, it's 2:1, that is 2. And the thickness is also 4 is more than 2, and 2 is less than 2. We can write it like that. Now, in twin peak sign or lambda sign is seen in DCTA, and T sign is seen in MCDA and MCMA. And one important thing is deep vascular connections. This whole thing is very important in MCDA. So most commonly, twin to twin transmission syndrome is seen in MCDA, and cord entanglement is mostly seen in MCMA. Now, complications. So it's the important part of the question. So I'll just hold it like this, and you can by yourself study the complications. Next, moving upon, you can see here twin to twin transfusion syndrome. Basically, the blood flows from the donor to the recipient, and hence there is increase. So we have to remember the renal outcome in both of the babies, the cardiac outcome in both of the babies, then the amniotic fluid level in both of the babies, and the complications in both of the babies. Everything that is reflected upon in this table quite clearly. Moving forward, this twin anemia polycythemia sequence, here it's quite the same only. Basically, one baby will have anemia, one will have polycythemia. That's about it. And then here you can see that we have twin reversed arterial perfusion, or TRAP. Here what happens is, normally the umbilical vein carries the oxygenated blood to the fetus, and the umbilical artery brings the deoxygenated blood back to the placenta. But here there is a reversal. The umbilical artery, instead of going to the placenta, goes into the donor or the acardiac twin, in which deoxygenated blood is pumped. As a result, either only the lower part of the baby develops, or an amorphous mass is formed which is expelled outwards. Now, regarding delivery in pregnancy, twin pregnancy. So delivering twin pregnancy, I'll explain here. See, delivering twin pregnancy basically depends upon the first twin. The first twin is the twin that lies closer to the internal os and gets out or delivered first. Now this first twin and consequently the other will be the second twin. Now the most common presentation is vertex for both first and second twins. If this is the case, then simple vaginal delivery will suffice. And now depending upon the first twin, we'll see the rest of the scenario. So if the first twin here is breech or transverse, you directly go for a cesarean section, no question asked. But if the first twin is vertex, then we see what the second twins are. If the first twin is vertex and here is the second twin, if it is also vertex, then we go for a vaginal delivery. But if it is breech, for the first one we do vaginal delivery. For the first one we still do vaginal delivery, but for the second one we do assisted breech delivery or ABD. And if the second twin is transverse, for the first baby we still do what is called our vaginal delivery, but for the second what we do is we do internal podiac version in OT under general anesthesia and then convert the transverse twin into breech. Basically, we take the patient up to the OT, hook her up with the general anesthesia, and then we insert our hand manually in the uterus and then hold the limb of the baby and convert it into a breech presentation. And after breech presentation, we do breech extraction. So this is or ABD basically. So this is the algorithm. Thank you.